A patient came to see me at 3 months post his hip replacement because he fell off a bike, and he wanted to check if everything was okay and if he was all right to continue doing his exercises. So as you can see, I was getting a bit of tachycardia watching him show me what he was doing, and the reason for that was because the dislocation of a prosthetic hip joint continues to be a major cause of failure in hip replacement surgery. And the causes or the factors that contribute to it, in my mind, are a combination of 4 things. Component design, which relates to primary arc, jump distance, head-neck ratios, etc. Component position, which is where you put it in. Soft tissue tension, which refers to your ability to restore offset and leg length and maintain the tension in the tissues for optimum function. And soft tissue function, which is obviously the integrity of the soft tissue envelope, which the Almighty has put in there to keep your native hip stable, which hopefully will impart some stability to the prosthetic hip as well. We'll just skip over these for the interest of time. Primary arc is the point of impingement, the distance traveled up to the point of impingement, and jump distance is the distance further traveled from that point before the head comes out. So anything that increases primary arc and jump distance will improve stability, and anything and vice versa. In regards to component positioning, I think the technical aim of implantation should be so that you get the implant construct position in a way where the center of rotation of the implanted construct is coincident with that patient's functional range of motion. And if you do that, then I think you'll have the maximum impingement-free stable range. And this may or may not be in keeping with the traditional recommendations of the 40-20, etc. And soft tissue tension, of course, well, this is to do with integrity of the soft tissue envelope, and that is predominantly the abductors. At the front, the iliofemoral ligament, which is the strongest ligament in the body. At the back, the external rotators and the ischiofemoral ligament, and of course, pubofemoral inferiorly. So, irrespective of approach, depending on how you do your operation, there'll always be a varying degree of compromise of the soft tissue envelope. And if you're going from the front, either with anterolateral or direct lateral or direct anterior, you obviously will affect the iliofemoral ligament and perhaps part of the abductors. And if you're going from the back, the external rotators and the iliofemoral ligament, or ischiofemoral ligament. And that is the reason for the traditional hip precautions. We've all seen this as a recommendation. This is not approach specific, and we've all seen these and recommendations to do this. But this, I mean, I'd imagine it'd be very difficult to do this, especially if you've been doing something differently for the rest of your life. You come to this part of the world, it gets even more complicated. And I was talking to Dr. Yadav before, and a couple of colleagues who said that after a total hip replacement in the subcontinent, the recommendation is to generally avoid the Indian-style toilet, and hip precautions are recommended usually for 6 to 8 weeks or 3 months by some people. Obviously, that will vary according to approach, but even the minimally invasive techniques, including direct anterior, has documented hip precautions recommended by a lot of surgeons, and this might be more in the way of avoiding hyperextension or external rotation and inflection. And these recommendations are not willy-nilly. You know, this is the British Hip Society patient booklet. And the duration as to how long hip precautions are to continue is also very obscure. No one really knows. But as I said, you know, 4 to 8 weeks, 3 months, or are they permanent? We don't really know, but most people recommend a month and a half or so. But you'd imagine by 6 weeks, the soft tissue envelope would have healed enough to give some stability, proprioception would have hopefully improved. But in that 4 to 6 weeks, obviously it has a significant impact on the patient. It's impractical, impedes return to function, transportation, and according to some authors, may even impact on patient satisfaction. And then, in that case mix, you throw in the current patient, high demand, wants to get back to work quickly, and wants to do more early. You then add newer approaches claiming to be able to deliver that based on soft tissue preservation and the preclusion of hip precautions. But if you look at the bottom line in regards to literature to support any of it, there's a great paucity of literature about hip precautions. So I thought I'd just quickly go through a few studies. There's not many. This is one from 2005 by Peak et al. And J. Pavesi. Good design, 265 patients randomized into 2 groups. restricted and unrestricted with a 6-month follow-up, and they found one dislocation, which was in the restricted group. But then when you look at it carefully, in the methodology, there's the restricted group and the unrestricted group. The unrestricted group had standard restrictions, and the restricted group had even more restrictions. These guys also found similar results, no difference in dislocation rates. They were predominantly anterolateral approach, which is similar to the previous slide as well. This is a rehabilitative publication by allied health and rehab physicians. And I think they started off with the intention of doing a meta-analysis, but they probably soon changed their intention, starting with 80 papers, which then diluted to 5, and then only 2 eligible studies, which again, were only looking at anterolateral and direct lateral. So they concluded that in that particular approach, hip precautions did not really change anything. In fact, if anything, they potentially negatively impacted the outcomes. A relatively high volume surgeon from the States, 800 hips, retrospective review, they looked at whether it made any difference to reduce the hip precautions from 6 weeks to 4 weeks. And they concluded there was no difference. Their dislocation rates were 1%, but again, looking at the study, no control group, and they had, I think, 8 dislocations. Most of them were early from what I can see, so a bit unclear. Unfortunately, this one didn't get past the publication of a protocol, but the same authors then published something last year in JBJS British, a prospective non-randomized study of 217 patients, including posterior approach. And they found that if the posterior capsule and posterior soft tissues were meticulously repaired, it made no difference. Now, this is an important one, again, an allied health publication, and I'll tell you in a second why it's important in that they found 95% of allied health professionals felt that the restrictions were a dogma, and we had to advise patients of that. And most of them thought they were permanent for life. And these are the people that are educating their patients before and after. And so there's clear disconnect between their expectations and the expectations of a lot of the practitioners. Similar prospective study of about 500 cases, but again, anterolateral approach. And then this one by Parvezi et al., looking at 2,500 hips. Again, only looking at direct anterior and anterolateral. And they didn't also find any difference between restricted and unrestricted. These are results I presented a couple of years ago, my first 100 of this particular approach. On functional results, we went to being able to dress ourselves and get to shoes and socks by 2 weeks in majority of patients, including work. A third of them went back to work by 1 week, and half by 2 weeks of the people that were working full-time prior, and most were driving by 4 weeks without any hip precautions. In fact, if anything, I was encouraging them to flex their hip up and get to their shoes in external rotation. I guess from all this, I concluded that there isn't really enough literature to make any guidelines. We also know from the literature that with capsular closure, posterior approach, and other approach dislocation rates are very similar. And all standard hip precautions may not apply to every patient, because either they may not offer anything in addition, or the patient may not need them. But ultimately, the call has to be made by the surgeon based on their own assessment of the individual case. And as long as they address the Fantastic Four and they check stability on the table, there's no reason why they'd have to restrict their patient. Thank you.
Thank you, Dr.